All right. Good morning, good afternoon, everyone. Once again, you're welcome to the Critical Care Fellows lecture series, a collaboration between the collaboration between John Hopkins Center for Emergency Care, Global Emergency Care, Kolebu Teaching Hospital, and the St. Paul's Hospital Millennium Medical Center in Ethiopia. This week we are honored to have with us Dr. Brad Winters. Dr. Brad Winters is a critical care medicine physician and an anesthesiologist with clinical work experience in cardiac surgical critical care, medical critical care, surgical critical care, and neurocritical care, and Ben's critical care. He is currently the division director for critical care medicine in the Department of Anesthesiology and Critical Care Medicine and co-director of the John Hopkins and Bayview Medical Center Surgical and Ben's ICU. His research interests are focused on early recognition and response to clinical deterioration and preventing hospital-acquired infections. Brad is a fellow of the Academy of Critical Care Medicine. His avocation includes cycling, kayaking, ice climbing, and playing the bass. Brad, you're welcome to join us. We're honored to have you present on the evidence ventilator-associated pneumonia. Thank you.
Great. Thank you very much for inviting me. I will apologize. I'm just getting over a cold, so I may cough a few times during the presentation. I apologize for that. So let me go ahead and get my screen up and shared here. Give me just a second. All right. Slideshow. Play from start. There we go. Can everybody see the slides?
Looks great.
Yes.
Okay.
Yes, we can see you.
Just double checking. Okay, so welcome everybody. Good afternoon. We're going to be talking today about ventilator-associated pneumonia, and I will start off by with my disclosures. I do some paid consultant work for Philips Corporation, based in the Netherlands, and that's primarily deterioration monitoring consultation. So it really doesn't have anything to do with ventilator-associated pneumonia. But I am the principal investigator also on a large U.S. government contract project to address hospital-acquired infections in the United States. And one of those infections is, in fact, ventilator-associated pneumonia. So actually, what a lot I'm going to be talking about today is already evidence that's beginning to come out of that project. So fairly updated, very relevant information for anybody who's interested in this particular area and preventing this problem in ICUs. So our learning objectives today are, first of all, to have a working knowledge of the definition for ventilator-associated pneumonia. And when I show you the actual definition by the American Center for Disease Control, you'll see why I say you want to have a working knowledge, because the actual definition that has been developed is rather complicated. We're going to talk about it a little bit, but we're not going to focus on it too much. But the most important thing I would like you to come away from this talk this morning is to be able to describe the various preventative measures that work to prevent ventilator-associated pneumonia, and especially to know which ones work the best, which ones have the strongest evidence. And that way, as a learning objective, you should be able to develop and implement your own bundle of interventions to help control and reduce ventilator-associated pneumonia in your own hospital. So I think everybody's probably seen at least a picture of one of these. I don't know if anybody's actually seen one in person. I have. These are the old iron lungs that were first widely constructed and developed to treat the polio epidemics that were rampant until polio vaccine became available. And of course, these devices worked by what was called negative pressure ventilation. They dropped the pressure around the patient to help them expand their chest as they took an inspiration. Needless to say, this is a non-invasive device. There's no breathing tube in the patient, just a rubber collar that kind of seals around their neck so that the negative pressure in the machine will be retained and hopefully support them as their own weakened muscles, originally primarily from polio, but we also see it in some other conditions, would actually be able to take an adequate tidal volume. Needless to say, this device is fairly effective for people who have weak musculature for a variety of diseases, but it's not particularly good for modern diseases that we deal with, like acute respiratory distress syndrome, severe aspiration, pneumonitis, pneumonia. It really just is not a great device for that. And as the polio epidemics began to wane, as vaccination around the world became ubiquitous, we've moved on to modern positive pressure ventilation. And this is just a picture of one particular brand of modern ventilator that you can find around the world. Obviously, many different manufacturers make them. They all look a little bit different. They have some different features. They do different modes. But the key thing with the modern positive pressure ventilation is that, generally speaking, they are invasive. These usually involve using an endotracheal tube, which has to go obviously through the vocal cords, although some of them can also do non-invasive positive pressure ventilation through what's called BiPAP or CPAP mode. But generally speaking, if everybody here knows, you walk into the ICU, you see someone on a ventilator, you're going to see a device that looks somewhat similar to this, and it's going to be connected to a breathing tube that's in between the patient's vocal cord into their trachea. Great for all the kinds of diseases that we deal with now. We don't see polio anymore. We do still see some muscle weakness diseases, but in our ICUs, we're treating, sepsis, ARDS, pneumonia, multi-trauma. These are devices that are quite uniquely designed and adapted to the kinds of problems that we deal in our modern time. However, they come with complications. Okay, they are great devices. We save lives with these machines, but they do have their own individual problems. And one of the big problems, of course, is barotrauma, the ability to cause a pneumothorax, or even at the micro level. We know now, based on a lot of research, that excessive driving pressures and excessive airway pressures actually cause tissue damage and inflammation. That's a whole nother talk in of itself, but barotrauma and microbarotrauma is a huge problem associated with positive pressure ventilation. I think everybody's also aware of dyssynchrony being a huge problem. Patients not being able to breathe in concert with the ventilator can also contribute to barotrauma, but also can contribute to delirium, all kinds of other difficulties, blood pressure problems, et cetera. And so dyssynchrony is a huge issue. Negative pressure ventilators didn't usually do that because they were triggered by the patient trying to take a breath. We try to control that on modern ventilators through valves that sense when the patient tries to take a breath, but particularly, as you guys all know, when someone particularly is breathing fast or is particularly unwell, dyssynchrony is a huge problem, and it can cause a lot of complications. And of course, to tolerate being on a positive pressure ventilator, especially when dyssynchrony is a particular problem in any one patient, you need to sedate people, generally speaking. And we know that sedation comes with all kinds of complications. Again, a whole nother talk in of itself. But, suffice it to say, the need to sedate people and sometimes even paralyze them chemically in order to tolerate ventilation is a huge problem. And of course, the really big problem that we're speaking about today is ventilator-associated pneumonia, which unfortunately is incredibly common in ICUs. So before 2015, the VAP definition that was commonly used both in Europe, the United States, I presume also in Africa and Asia and Australia and other countries around the world, primarily included systemic signs such as the patient was developing a fever, or perhaps they were getting hypothermic, but usually a fever. And they developed an elevated white blood cell count. And then we would get a chest x-ray, and we would find on the chest x-ray, or if you went to the level of doing a CT scan, which not everybody does or has access to, there were signs suggestive of infection. There were infiltrates on the chest x-ray, things that looked like a pneumonia developing. And of course, looking at the sputum characteristics, was it purulent? Was it yellow? Was it green? Did the characteristics look like this might be infection? And of course, taking cultures either by suctioning out some cultures from the endotracheal tube, or if you went as far as doing a bronchoscopy to get a sample through a bronchoscope. And, that definition was pretty good. We were using it for many, many different years. But data started to accumulate in the decade before 2015 to suggest that radiological assessment was unreliable. We as doctors were lousy at reading chest x-rays. It turned out that we were not as good as we thought we were at differentiating whether something was an infectious infiltrate or just atelectasis, collapse, or even just localized pulmonary edema. And so between 2014 and 2015, the Centers for Disease Control in the United States underwent this huge change in how we define ventilator-associated pneumonia. And I will tell you, there was a huge project that was funded by the US government trying to address ventilator-associated pneumonia at the time. And this change in definition actually was a big problem for us, because all of a sudden hospitals around the United States suddenly were shifting how they defined ventilator-associated pneumonia, and it actually created a lot of difficulties for the study. But to suffice it to say, in 2015, the US Centers for Disease Control redefined ventilator-associated pneumonia into a much larger grouping of a disease state called a ventilator-associated event. And we're going to talk a little bit about that. So the fine print, so to speak, the VAP definition. We're going to read through this really quickly, and it may make your head spin because it's confusing. And this is only part of the definition. I pulled this out of the Center for Disease Control website, and in fact, it's probably a 10-page long definition with excruciating detail, but these are the core components of it. Patients must be mechanically ventilated for at least 4 calendar days before you can even enter this definition of ventilator-associated events. And this is where the day of intubation and initiation of mechanical ventilation is considered day 1. Okay, well, I got to move something here. The earliest date for an event for a VAE, the date of the onset of worsening oxygenation, therefore becomes day 3 of mechanical ventilation. Okay, so you have to be on the vent for at least 4 days, but the earliest that you could be diagnosed with a ventilator-associated event is actually day 3, the day before that day 4. And the baseline period of oxygen stability or improvement on the ventilator is defined as 2 calendar days immediately preceding the first day of increased minimum PEEP or FiO2. Okay, and then they have this rule here about characterizing greater than or equal to 2 calendar days of stability, and they define what's referred to as the minimum FiO2 or PEEP. Suffice it to say, minimum PEEP is anywhere between 0 and 5 of positive end expiratory pressure, and whatever the minimal oxygen setting was that you had on the ventilator. So it must be characterized by at least 2 calendar days of stable or decreasing minimum FiO2 or PEEP. That is, you drop it to a minimum, specifically the daily minimum PEEP or FiO2 on the second day of the baseline period of stability or improvement must be equal to or less than the daily minimum PEEP or FiO2 on the final day of the baseline period. The definitions of daily minimum PEEP or daily minimum oxygen are included below. And that involves a whole nother very complicated definition. And these minimum PEEPs or FiO2 measurements have to be sustained for at least an hour to define them as the minimum PEEPs. And for the purposes of ventilator-associated event surveillance, PEEP values, as I said before, between 0 and 5 are considered equivalent. So whatever you set your minimum PEEP to If it's between 0 and 5, that's all considered the same number. And this means that patients with daily minimum PEEP values from 0 to 5 must then have an increase in the daily minimum PEEP to at least 8 centimeters of water sustained for at least 2 calendar days to meet the ventilator-associated condition definition. And so, of course, the big question comes up, what did he just say? What was all that? I will tell you that it has gotten so confusing based on this incredibly long, complicated definition for ventilator-associated events, and then embedded within it, ventilator-associated pneumonia, that many doctors, intensivists in the United States, are literally throwing up their hands saying, based on this new definition, I don't really know how to diagnose ventilator-associated pneumonia anymore. But I'm going to try to distill it down to make it as straightforward as possible so you have a bit of a working definition derived from this incredibly complicated Center for Disease Control definition. So basically what it means is after you have a period of stability or improvement on the ventilator in terms of oxygenation, you were never on a lot of oxygen, or you got the oxygen way down and you got the PEEP way down and things were looking pretty good, that all of a sudden you have to go up on the PEEP or you have to go up on the oxygenation, or both. If you are on a lower level of PEEP or oxygen for a day or so and things look stable, and all of a sudden you are now increasing oxygen or increasing the PEEP to respond to hypoxia, basically you've got a ventilator-associated event. And they do give some numerical values here, but I think at the side of the bed, we all know that if we were down to 8 of PEEP and we were down to 40% FiO2 on our patient with the ventilator, and suddenly we are now up to 60%, or we've had to go up to the PEEP to 10 or 12 and add additional oxygen, we know we've had a deterioration. And you now probably have what's called a ventilator-associated event or a ventilator-associated condition. But that doesn't mean you have a VAP yet. Changes in oxygenation, as I think everybody knows, are not always due to pulmonary infection. Obviously, pulmonary embolism is a common cause of why people deteriorate their oxygenation, and we have to respond by changing the ventilator. Excuse me. Mucus plugging, common problem. Atelectasis, very common problem in the ICU. So all of those can lead to needs to increase oxygenation. And of course, if your patient is developing sepsis from another source, they could develop septic shunting in their lungs as well, which can lead to the increased need for PEEP and or oxygenation. So, and this is not an exhaustive list. There are probably several other things you could think of that are going to impair a patient's oxygenation, and they're all considered ventilator-associated conditions, and they all have their own specific treatments, but they aren't a pneumonia. They are not an infection. And this is where there's a lot of confusion and, to be honest, a lot of complaining about the definition in the United States. And I'll tell you that those complaints and confusion about this definition are so strong that in the United States, our government tracks a whole bunch of infections that occur in our hospitals, such as central line associated sepsis, infections associated with Foley urinary catheters. But interestingly, the government does not follow ventilator-associated pneumonia. Part of the reason for that is this definition is so hard to follow and so hard to apply at the patient's bedside. And this is unfortunate because, excuse me, at least in the United States, ventilator-associated pneumonia is probably the most common and most lethal infection that we deal with in the ICU. We've gotten very good at preventing central line infections. We've gotten very good at preventing Foley catheter-associated infections. This particular disease is probably the biggest infectious threat besides garden variety sepsis in our patient population, because a lot of people are on mechanical ventilation. And the problem is the definition is just unworkable. So again, to have a good working definition basically means if you've gotten the patient better and they've stayed better in terms of their oxygenation for a day or two, and now they're getting worse, and you have to go up on oxygen or up on PEEP, you have a VAE and you might have a ventilator-associated pneumonia, although you could have one of these other problems I have listed here. But what you're going to do is obviously you're going to investigate all these. You're going to try to determine whether you've got a pulmonary embolism. Mucus plugging, you could try to treat that with suctioning. Atelectasis, you could try to diagnose that on a chest x-ray, or if you have available the ability to do a CT scan. And of course, we're always watching for sepsis in our patients. But if you're looking specifically for a pneumonia associated with being on the ventilator, that gets us into the next level of the process. So moving from a ventilator-associated condition to what is called an IVAC, or an infectious ventilator-associated condition, which is not absolutely an infection, but is a more likely infection, is on or after that day 3 that I mentioned before of mechanical ventilation, and within 2 calendar days before or after the onset of that worsening oxygenation, the patient meets a couple of criteria. One, they've got a temperature, they're febrile, or they're hypothermic, and or they've got a white blood cell count that's gone up or is now leukopenic, and a new antimicrobial agent has to be started and is continued for at least 4 qualifying days. So if you basically feel the need to start antibiotics clinically, or you've got some of the older definitions that go along with infection, such as an elevated white blood cell count or fever, this is now considered an infectious ventilator-associated condition. But it's still not definitely a VAP, right? Because we start antibiotics for lots of reasons. And as you can see here, there's nothing definite that tells us there's an infection in the lung here. Could be, but not necessarily. So to move over to where it's really actually probably a VAP or certainly a VAP, again, that day 3 point after mechanical ventilation, and again, within 2 calendar days after the worsening of oxygenation, one of these things happens. Criterion 1, you get a positive culture out of the lungs. Okay, and that could be from an endotracheal aspirate just by suctioning it into a sampling tube and sending it off, a bronchoalveolar lavage if you happen to have a bronchoscope and do a bronchoscopy, or lung tissue from a biopsy, which is not a very common way of doing it, or what's called a protected brush specimen, which is a specialty procedure that's not very often done. But as you can see, these have some very specific numbers attached to them. 105 colony-forming units, 104. To be honest, most people don't follow this rule. This is actually a very uncommonly applied criterion for deciding now that we have a VAP. What is more commonly done, and is probably closer to what we used to do before 2015, is criterion 2. We have purulent respiratory secretions. We suction them out. We've got a lot of neutrophils without a lot of squamous cells on gram stain, and we grow out an organism from either a sputum or an endotracheal aspirate or a bronchoalveolar lavage, or again, some of those other less commonly done things. So basically, we've got sputum that looks infected. It's got neutrophils in it. It's a good sample, and it grows out a bug. This is just the way we used to do it years ago, and this is still probably the most common way we all diagnose a VAP now, despite this new, very complicated definition that's been in place for a while. Another possible way of doing it is through what's called criterion 3, is that you get pleural fluid. You do a thoracentesis, and you find you've got bacteria. You've got an infected pleural effusion. You've got an empyema. And so if you get bugs in pleural fluid, that also meets it. Or if somebody, for some reason, takes a sample and you find you've got an abscess in the lung, like from a surgical specimen. Or you've got a diagnostic test for Legionnaire's disease, which, of course, is not actually from the lung. We actually measure that in the urine. Or a positive test for a number of various respiratory viruses, including influenza, human metapneumovirus, or coronavirus, or adenovirus, etc., if you happen to be able to test for and culture for a virus. And again, this is also a fairly common way of making the diagnosis, but criterion 2 is also probably equally as common. And so in the end, after this very complicated definition was put into place that confused everybody in the United States and Europe and everywhere else, in the end, we're probably still clinically at the bedside, still doing it the way we've always done it. We probably still also look at x-rays or CT scans if we have a CT scan available, and still trying to determine whether it's an actual infectious infiltrate, even though we already know that we're not that good at it. And so unfortunately, knowing that you've got a VAP and making the definition of a VAP is really, really difficult. In the end, clinicians generally know a VAP when they see it. And so we clinically at the side of the bed don't usually use the CDC definition, except some small components of it. And again, as I mentioned before, it's probably one of the reasons why in the United States, at least, this is not a mandatory reportable condition that we have to provide to the government, unlike a lot of other diseases that we actually do have to track. So suffice it to say, that's the VAP definition. Complicated, but again, at the bedside, clinically, we're probably still doing things the way we always have, just because the new definition is not really any better at the bedside. VAP treatment, I'm not going to dwell on this a lot because I want to move on to the preventative measures in a moment, because that's where I think the real benefit and opportunity lies. VAP treatment, of course, is pretty straightforward. Empiric antibiotic coverage while you await cultures. You have to account for the likely local organisms. So in your hospital, wherever you work, you need to know from the micro lab, what are the most common organisms you do see? If you see a lot of Pseudomonas, or if you see a lot of Enterobacteriaceae in your like Enterobacter and E. coli, or you see a lot of other organisms. You want to know what is the common bugs, the common bacteria where you work, because on one side of the city, your hospital may see a lot of one type of bugs, but a hospital on the other side of your city or town over may see a very different kind of bacterial situation in ventilator-associated pneumonia. So you want to know what the local bugs are. And you want to know what the local bacterial antibiotic sensitivities are. You want to know what will likely work when you start empiric coverage. So just as an example, if most of your VAP is due to Pseudomonas, and your Pseudomonas isolates are not usually sensitive to a drug like piperacillin tazobactam, then maybe your first empiric choice is going to be a drug like cefepime, okay, or ceftazidime. And then when your culture results come back, of course, you're going to need to change your antibiotics depending on what the identified bacteria actually is sensitive to. And you also would need to account for what is likely in this particular patient in front of you. So did they have a VAP 2 weeks ago? Or do you know that they have other infections with a particular bug that now could be the cause of a VAP? You also want to know, is this patient colonized? Because while people are colonized, and we usually don't treat colonization, actually we should not treat colonization, sometimes colonization will turn into a new active infection. So you just need to be cognizant of what's likely in your hospital, how sensitive is it likely to be to certain antibiotics that you have at your availability, and again, on the individual patient basis, try to get an assessment of what you think is most likely in this particular patient. Of course, gram-negative bacilli are the most common culprits, but staph is also a big problem in many ICUs. And again, you have to tailor your antibiotics based on culture and sensitivity results. And in that sense, VAP is fairly straightforward in terms of making those decisions. The one area that does create a lot of discussion, shall we say, around the bedside is how long are we going to treat with antibiotics? There is now data in the literature that shows that courses as short as 4 days are sufficient under many circumstances, but unfortunately it needs to be borne out in much larger clinical trials. There are a handful of smaller clinical trials showing that this works and is safe, but before it becomes a common recommendation to ratchet down the duration of antibiotics to 4 days, we need some bigger studies. However, generally 7 days are usual. Years ago, when I was a fellow myself many years ago, we always treated VAP for 2 weeks straight. We are now down to 7 days for most VAP conditions. depending on how the patient is responding. Sometimes we'll extend that to 10 days. But generally speaking, the shorter the antibiotic course, probably the better. And the reason is the longer you're exposed to antibiotics, the more likely you are to develop resistant organisms in the lungs or engender diseases like Clostridioides difficile, which of course, can become, devastating for some patients. So suffice it to say, we're going to stop there in terms of VAP treatment. Let's talk about VAP prevention, because this is where the opportunity really lies. Okay. And the best way to manage VAP is really to try and avoid it right from the beginning. And there are a whole bunch of very evidence-based approaches that will help with this. In 2022, a large compendium on preventing hospital-acquired infections was published, and it included a large section on ventilator-associated pneumonia. And as I mentioned before, I'm the PI, the principal investigator for a large national project looking at several HAIs in the United States, hospital-acquired infections. And we have recently updated that compendium with the most recent evidence. And I'm actually going to present that evidence to you today, even though it's not published yet. Okay, so this is, as they say, hot off the presses in terms of newspapers or being online these days. I don't think anybody reads newspapers anymore. There are 4 opportunities to prevent what's called device-associated infections, and VAP is a device-associated infection. It's associated with the mechanical ventilator device. Okay, this also applies to things like central lines, Foley catheters, and other hardware that we put in patients. Okay, don't use the device in the first place. Don't use the ventilator if you can avoid it. Not always possible, but there are some other ways to avoid using an invasive mechanical ventilator, and we'll talk about those in a minute. Remove the device as soon as possible. Try to get them off mechanical ventilation as quickly as you possibly can. And the reason is the longer you are on mechanical ventilation, your VAP risk accumulates. After the 3rd day, it jumps generally from 0 up to about 4%, and then increases 2 to 3% every day after, which means if you're on the ventilator for 10 days, you are well over 25% likely to get a VAP. That means 1 out of every 4 patients is going to get a VAP. So the shorter you can keep the patient on mechanical ventilation, the less likely you are going to get this problem. Minimize risk for infection at the time of insertion. That's a little hard for mechanical ventilation, but we're going to talk a little bit about one strategy that people have attempted to actually address that, and we'll come to that in a little bit later. Use maintenance practices that minimize infection risks. So good practice around the ventilator and the endotracheal tube. We're going to talk about a whole bunch of those. In fact, all of the preventative measures I'm going to talk about directly or indirectly address each one of these. Again, I mentioned that compendium. It's published in the literature. You can find it online. Several organizations, including the Society for Hospital Epidemiologists, Infection Control Officers, and the Infectious Disease Society of America, published this systematic review of practices to prevent VAP in 2022. And again, we have just recently done a big environmental scan updating this data. And the following slides are based on the compendium and the newest data that we've accumulated for the purposes of this project. So that first one, avoid using the device. So how do we avoid using mechanical ventilation? This is considered by the compendium and based on the newest evidence to be what's called an essential practice. This is something that everybody should be doing for every patient with respiratory difficulties. It's hard to avoid mechanical ventilation when the patient really needs it. But if you have it at your disposal, using CPAP or BiPAP has been shown in many, many studies to be very effective at helping people get through a respiratory distress or respiratory insufficiency situation without having to put them on an invasive mechanical ventilator. And I know in the United States, I'm not sure how available it is in Africa, high flow nasal cannula, which is like the regular little nasal cannulas, except it's a plug that goes in your nose, so it seals really well, has become a very popular tool for treating hypoxia and trying to avoid going to mechanical ventilation in the United States. It's much easier to do than BiPAP, and it works for a lot of patients. Of course, as I said before, you can't develop a ventilator-associated pneumonia if you are not on a ventilator. Again, unfortunately, sometimes any one of these strategies, along with good clinical care, does not prevent you from having to intubate somebody and put them on a mechanical ventilator. So this is an essential practice, but unfortunately, it's not always possible. So if you do need to still put the patient on a mechanical ventilator, there are a bunch of things you can do once you've had to go down that route. And one of the things that is recommended by the compendium and by the most recent evidence in the literature is something called a subglottic endotracheal tube. So a huge reason behind why people are thought to develop VAPs, ventilator-associated pneumonia, is that little cuff that you could see in the trachea there seals against the wall of the trachea. But it is not a perfect seal. When patients cough, when they get moved around, that cuff shifts, and it can allow secretions that have drained from the nasopharynx and the oropharynx around the endotracheal tube and past the vocal cords to pool here above the cuff. And then when the cuff seal is lost for a few seconds, these secretions, where it says pooled secretions, can then work their way past the cuff, and they get down into the lungs. And that is thought to be a major mechanism of why people develop VAP, is they basically inhale around the cuff on an endotracheal tube these secretions. So these special endotracheal tubes have been developed that they have a little port right above the cuff, a little hole, and there's a channel that runs up the endotracheal tube that you connect it to a suction device, and it helps pull those secretions out. So there's less of it there, less bacterial burden, and hopefully less chance of getting a large amount of bacteria around the cuff and down into the lungs. One study in 2017 demonstrated that despite the increased cost of these endotracheal tubes, and I will tell you, they cost about 20 times the cost of a regular endotracheal tube. So in the United States, a regular breathing tube costs about $1 US. These special tubes cost more like $20 US. So they are a lot more expensive. But there was a study in France in 2017 that showed that despite this increased cost, they were cost effective because they are pretty good at reducing ventilator-associated pneumonia. In fact, that compendium from 2022 probably would have recommended these as an essential practice, except they cost a lot more. And in many countries, they're too expensive. They're very expensive to use. And the other problem is it's often hard to know when to use them. It's hard to predict who's going to be on a ventilator for more than 3 days, which of course is when you start getting into the VAP definition. And so it's hard to know when these are cost effective to use. And again, we only have that one cost effectiveness study. And so we use them, at least at Johns Hopkins, for when we have to emergently intubate people on the regular hospital floor or reintubate people in the ICU, because we suspect that if you have to get intubated under those conditions, you're probably going to be on the ventilator for a while, but we don't routinely use them in the operating room. But every individual hospital has to decide how much can they afford to buy these, and who should they use them in. But again, they do work. They do reduce ventilator-associated pneumonia, but again, it has to be a local decision whether they are cost-effective to use widely or in a very restricted patient population in your hospital. But they do work. Probiotics, symbiotics. There is a lot of literature on this in the last 4 or 5 years. A lot. This has become a very hot topic for a lot of problems in the ICU and just in medical care in general. And basically what this involves is organisms like lactobacillus and other cultures and similar gut supporting organisms found in things like yogurt, kefir, and other fermented foods that are very common in many cultures around the world, and basically giving these to people to help control gut overgrowth and help protect them against VAP, as well as other diseases such as sepsis. And again, there's a large number of systematic reviews looking at this. The problem is, if you look across those systematic reviews, they all tend to re-review the same primary studies over and over. There's something like 8 systematic reviews in the last 6 years, and they tend to look at the same articles. And some find benefit and some don't. Most importantly, in 2021, Johnston et al. In the New England Journal of Medicine published the largest randomized controlled trial of over 2,600 patients using probiotics like this, giving people lactobacillus and other organisms, found no benefit in preventing VAP. And Lee et al. In 2023 performed a very high quality systematic review and meta-analysis and found that only the poor quality studies found a benefit from this. If you separated all the primary studies into low quality ones versus the really well done studies, the well done studies did not find a benefit. And Han et al. In 2021 did a very large systematic review, and basically they kind of found the same thing that Lee did. They said they couldn't even draw a conclusion because so many of the studies that were reviewed in all the other systematic reviews were so poor quality and so heterogeneous that you couldn't even draw a conclusion. As such, these are not recommended. The compendium does not recommend them, and the most recent data does not support recommending using these to prevent VAP. What about prophylactic antibiotics? Remember I mentioned a few slides ago about when you insert the endotracheal tube, when you insert the device, good practices for preventing infection are really important. That's especially important for things like central line infections and Foley catheter urinary tract infections. Aseptic technique, putting those in helps prevent infections associated with those devices. Of course, that's not really something we can do with putting an endotracheal tube in somebody. We have to do a laryngoscopy and we have to get the tube between the cords. It's usually very emergent, and there's really no way to be aseptic about it. There's no real way not to have bacteria there because you're putting it through the mouth. The compendium actually did not address this practice at all. However, we examined the literature and we find that based primarily on 2 RCTs, there were a couple other smaller, not as well done studies that were published as a compendium, prophylactic antibiotics actually may be considered as an additional approach, especially in neurologically injured patients. Most of these studies were done in people with traumatic brain injury or stroke, but it should be balanced against what your local pathogens look like. If you have a bad tendency for resistant bacteria in your hospital or your ICU, you'll want to be very careful about putting this in place. And if you choose to do so, you need to keep an eye on resistance patterns to make sure that giving prophylactic antibiotics, excuse me, does not drive up your resistance. The problem is, looking across the several studies that have examined this and found benefit, they all do it slightly differently. So we can't recommend one particular way of doing it. One study that was particularly nicely done, at the time of intubation, they gave a single dose of ceftriaxone at the time of intubation. That was the only dose they gave, and they found that reduced VAP. And another study actually gave inhaled amikacin for the first 3 days on the ventilator and also found tremendous benefit. Which one you choose? Do you choose to do both together? That's up to you. That will be your choice. But this appears potentially to be an effective approach. We do need more data on it, but it may be an effective approach when placing the endotracheal tube for mechanical ventilation. Oral care. For many years, it was recommended to use a chemical called chlorhexidine mouthwash to help clean the teeth to reduce bacterial burden. And remember, as I said before, with the subglottic endotracheal tubes, bacterial growth in that secretions that pool above the cuff is a big problem. Well, if we can reduce the bacterial burden in the mouth and in the oral pharynx, whatever secretions may accumulate there no matter what, if we can reduce the concentration of bacteria, we may be able to reduce VAP. And for the longest time, chlorhexidine was recommended. In fact, it's been recommended for quite a number of years. However, in 2022, the compendium dropped chlorhexidine mouthwash from its recommendation. The accumulated evidence over the years suggested that chlorhexidine didn't work any better than any other mouthwash. And a number of newer studies published since the compendium are actually quite heterogeneous. People have looked at all kinds of mouthwashes, Listerine. People have continued to look at chlorhexidine. People have looked at a bunch of herbal medicines, particularly in China. A lot of studies have been published looking at a variety of Chinese herbal medications. The bottom line is for oral care, all the data says that toothbrushing, hence the picture of toothbrushes, is incredibly effective, and that all of your patients should get their teeth brushed daily to reduce the bacterial burden and reduce VAP. It's very effective. But exactly what you use to brush their teeth, we don't know. You don't have to use chlorhexidine. If you choose to use chlorhexidine, fine. If you want to use Listerine or you want to use some other herbal medicine mouthwash, we don't know which one works the best. But we do know that mechanical toothbrushing works. And you can still just use water. You don't actually even have to use a mouthwash. But the key thing is toothbrushing helps clear out and dislodge bacterial plaque from the teeth and the gums, and seems to be incredibly effective at reducing VAP. And this is easy. Anybody can do this. You don't have to have fancy, expensive equipment like subglottic endotracheal tubes. Toothbrushes are pretty cheap. This is a very inexpensive, very effective way of reducing VAP. Key thing is to make sure it happens for every patient every day. Decontamination. There are two kinds of decontamination. There's skin decontamination and gastrointestinal decontamination. And there's a lot of literature out there looking at particularly GI decontamination for reducing sepsis. And we know there's a lot of literature out there for skin decontamination prior to surgery. But specifically for preventing ventilator-associated pneumonia, the 2022 compendium recommended against skin decontamination, which was usually done by using chlorhexidine bathing, wiping the patient down with chlorhexidine. And they did not recommend doing this because they found it just really didn't work for VAP. Doesn't mean it doesn't work for other things like surgical site infections, but specifically for VAP, it doesn't really work. And there's no new data to make a recommendation to change that. It's generally not recommended. Gastrointestinal decontamination, however, may be a bit of a different story. In 2022, Hammond et al. Published a systematic review and meta-analysis of 32 studies, a large number of patients, almost 25,000, and found that selective digestive decontamination reduced the risk of VAP substantially. But they did also conclude that it was of low certainty because of heterogeneity in the primary studies. But they still concluded that it did work. This practice is actually recommended by the compendium as an additional practice to consider in ICUs, but only in ICUs where you don't have a lot of resistance. That's becoming a less common situation. We're all seeing a lot more resistance. But if you think the resistant organisms in your ICU are not a tremendous problem, you can consider gut decontamination as a strategy to reduce VAP. Like prophylactic antibiotics, though, you probably want to keep an eye on your resistance patterns and make sure you're not making things worse by breeding resistant organisms through this practice. But it does seem to work. Early tracheostomy. Early trach is based on the hypothesis that it simplifies oral care, which it does because now the breathing tube's not in the mouth. You can do better toothbrushing, which we know works, and it often expedites separation from mechanical ventilation. Now, early tracheostomy helps with VAP, but it also helps with preventing long-term damage to the vocal cords and the trachea. If you look at the otolaryngology head and neck surgery literature, the ENT literature, in terms of long-term tracheal damage, we generally, it's recommended that tracheostomy should be done at 2 weeks of mechanical ventilation. If you are not going to get the patient off the ventilator by 2 weeks, you should be considering a surgical tracheostomy. And that's based just on damage to the glottis and the trachea. In terms of VAP, it is also benefit. So a large systematic review by Tavares et al. 2023 of over 14,000 patients found a statistically significant reduction doing early tracheostomy. This study was primarily limited again to neurologically injured patients, traumatic brain injuries, head trauma, as well as stroke patients. But Ferran et al. In 2022, smaller study, 2,800 patients, 17 studies in a systematic review, also found in a more general ICU population, not just traumatic brain injured or stroke patients, that it also was statistically significant in reducing VAP, although in that study, it was used as a secondary outcome, not the primary outcome. And again, as I mentioned before, early tracheostomy has other benefits besides reducing VAP. So the compendium recommends and advocates early trach as an additional approach to reduce VAP. The real question comes down to is, well, how early? We know based on damage to the vocal cords and the glottic structure that the ENT literature says by 2 weeks. The problem is, if you look across all the primary studies looking at early tracheostomy, some of these studies did the tracheostomy really early, like at day 3, which is incredibly early and probably not warranted. A lot of them looked at a week out, but again, a lot of them also look somewhere between a week and 2 weeks. So the problem is we don't know exactly what that time point should be. If you have a patient who's on the vent and you have a high suspicion they are not going to get off the vent by 1 to 2 weeks, around 1 week, you should probably start thinking about, should we do a tracheostomy in this patient? Certainly, again, coming back based on the ENT literature, layered on top of the VAP literature, by 2 weeks, you definitely should be considering it. You definitely should be doing a tracheostomy if you can. Obviously, I work in a burn ICU, and some of our patients we can't trach early because their necks are burned, and you can't trach through a burn. And so we have to get that healed up and repaired before we can actually do a tracheostomy in it. But if you can do the trach, you should be doing it around 2 weeks. Sedation management. Have to minimize sedation wherever possible. Okay, again, we mentioned that being on mechanical ventilation, the need for sedation is often problematic. And so unless contraindicated in your patient, doing a daily sedation hold, or what's referred to as sedation holiday or sedation vacation, is considered an essential practice that everybody should be doing. Every day, unless it's contraindicated, i.e. the patient's horribly unstable or something like that, we should be trying to turn off the sedation, get the patient awake, and see how they look. Okay, and the reason why you want to do this is if you could get them awake and they are not delirious and they remain hemodynamically stable during that period of time, you should then proceed to a spontaneous breathing trial where you try to put them down to minimal settings and see how well they can breathe. And then use that as a tool to decide, okay, can this patient be extubated? Can we take the breathing tube out and get them off the ventilator? And these two components, the daily sedation hold, called a spontaneous awakening trial, an SAT, or an SBT, a spontaneous breathing trial, are core components of the Society for Critical Care Medicine's ICU liberation program, which involves a whole bunch of individual interventions, but in particularly on every patient who can tolerate it or should be able to tolerate it, we should be doing this every day. It's been shown to help get people off the ventilator faster. And as we said, if you're not on the ventilator, you're at less risk of getting a ventilator-associated pneumonia. So if you can do this practice on every patient who qualifies every day, you should be able to get people off the ventilator faster, get them out of your ICU faster, and reduce the risk of VAP. Positioning. Keeping the patient at least 30 degrees recumbent is considered an essential practice based on over 25 years of the literature. all subsequent data still supports that. In fact, more recent data suggests that 45 degrees is probably even better. The problem with a lot of the studies is adherence to the practice is often low in a lot of studies, which has led people to argue about how effective it is. But if you put all the data over the last 25 years together, keeping people at least 30 degrees helps keep them from aspirating secretions down into their windpipe above that cuff. Again, reducing the burden of getting bacteria down into the lungs around the endotracheal tube cuff and getting the secretions to go down into their stomach, and also preventing them from vomiting or having passive reflux into their throat, also getting into their windpipe below their vocal cords. And again, 30 degrees is absolutely essential. Again, more recent data suggests that even 45 degrees is probably even better. Prone positioning, which became very common during the COVID pandemic to treat the ARDS associated with COVID, is not preventative. In fact, the data in the literature, there's not a lot of it. It may, in fact, be harmful. And therefore, proning patients may increase the risk for VAP. And that is concerning because we know that proning has been shown to be very effective for treating conditions like ARDS. So if your patient does have ARDS and they meet the criteria for being proned, you should still do it. But keep in mind, it may make your VAP rates a little bit worse because there is one reasonably well done study showing that prone positioning does increase the risk for VAP. But again, if you need to do it for other reasons, you need to do it. Bundled VAP interventions. Regardless of which intervention you choose, of all the ones I've just gone through, they should be bundled into a package. Two very large systematic reviews, one by Martinez-Revejo and Mastrogianni, both in 2023, found a statistically significant benefit when you bundled a bunch of interventions together. You got an additive or synergistic effect from each of these individual interventions alone. So let's say your hospital says, look, subglottic endotracheal tubes, they cost too much. We really can't afford to buy them. Okay, great. Try to do as many of the other things as you can and bundle them together. And in fact, the compendium recommends bundling, making sure you're doing more than one thing at once, is an essential practice that everybody should be doing. And in fact, while they did not address checklists directly, the Armstrong Institute for Patient Safety and Quality at Johns Hopkins strongly recommends building a checklist to round on your patients every day to make sure that whatever elements you put in your bundle are being done on every patient every day. So for example, that spontaneous awakening trial, did everybody who qualified or was safe to do a spontaneous awakening trial actually get it done today? Just a basic checklist. You could do it on your iPhone or your Android. You could do it on paper, whatever way you want to do it. But, keep track to make sure you're doing everything that you planned to do. And again, if you do that, you get a nice synergistic additive effect. And that's been shown quite consistently in the literature. So I'm going to stop there. Sorry, I apologize for my coughing. Again, I'm just getting over a cold. And I'll open it up for questions, thoughts, opinions, whatever you like.